Hi, my name is Rebecca Hancock, and I'm with the Patient Safety Center and the Indiana Hospital Association, and we're talking about sepsis during Sepsis Awareness Month in September. And today we're joined by Kaycee Barnett, who is the Sepsis Coordinator at Terre Haute Regional Hospital in Terre Haute, Indiana. And we're very privileged to have Kaycee speak to us because Terre Haute Regional is the first hospital in the state to receive Joint Commission certification for their sepsis care. And so Kaycee is going to share with us her pearls of wisdom as the sepsis nurse coordinator who has been leading this fight within their hospital and has had some successes with what she's doing and how she did that. So Kaycee, welcome, and please share with us your journey.
Thanks, Becky. My name is Kaycee. I have been with Terre Haute Regional for the last 8.5 years. The last 2.5 of those have been the sepsis coordinator, so other sepsis coordinators can feel my pain some days and my joy others. But yes, we were the first hospital in Indiana to be accredited by the Joint Commission in the care of sepsis patients, and ultimately our goal was to become the healthcare leader in sepsis care. We wanted to provide the highest quality care to our patients in our community because they're our family. We want to see them succeed, do well, and live a healthy lifestyle. So what we did as a facility, really just to begin certification, we took the Joint Commission specification manual, we looked at it, what did we really have to do set by the Joint Commission to become certified? And then we looked at our existing program, the data we had, and we asked ourselves, what were we going to do to improve the outcomes of our patients in our community and make sure it aligned with the evidence-based care of their surviving sepsis campaign? So we set some goals for ourselves. As a Joint Commission certified facility, we set goals and we work towards them. The Joint Commission recommends that you have 2. We tried to go above and beyond because we had a lot of areas to work on, so we set 4 for ourselves. Currently, our goals are antibiotic compliance within 1 hour, hemodynamic monitoring for septic shock patients. We look at initial screening accuracy in all septic patients, and appropriate fluid bolus for those patients that require it. So we really felt like those goals currently, 1, we had areas to improve, and 2, they would really help to increase the likelihood of survival and increase the quality of life that our patients, we strive for them to have. So administration buy-in, this is huge, and we're very fortunate at Regional to have administration buy-in around sepsis and all things quality care. So what we do, just overall, we start our employment at Regional with introducing our nurses and staff to just what sepsis is, what our sepsis protocols are, and what our goals are for improvement and how we're getting there. I sit down personally with each new ER provider and each new nurse and go over just a broad overview of sepsis and our protocols. And it's a really great way to introduce them to myself and to the program and to what focus we put on it. So that's a great way to increase engagement. Sepsis is just at the forefront of everything all nurses do. I feel like they clock in and they think, okay, what sepsis area am I going to see today? Because they know they're going to be affected by it at some point in their day. I want to be out front with them, go to their unit meetings, to their yearly skills fair. I send out education and updates. The other quality improvement coordinators talk with them about sepsis every day. It's a team effort. We want sepsis at the forefront, and if we're always talking about sepsis, they're always going to be assessing sepsis is what we feel. So just maintaining constant communication with the coworkers. What are your barriers to success? What are you seeing that your providers are having issues with? Or as a provider, what are your nurses having issues with? So we've really been able to work through a lot of areas that need revision just by asking the workers that are on the front lines, what are you seeing and what do you need help with? So really just in general, the Joint Commission certification is all about looking at what you have currently and making a way to improve on that, improving your patient outcomes and decreasing your mortality rate. So then I'll go into mortality. We have had pretty good success with maintaining a low mortality rate. We do that in several ways. So we really look at each mortality in general. We go into every sepsis mortality. What could we have done differently? What did we do right and what did we do wrong? We want to look at those and so that we can make sure we're not making any mistake if we did, missing something, or if we did something really well, we want to do it and replicate it again. We really look at those mortalities. We discuss them as an interdisciplinary team each month of what we could do to prevent future mortality. Also, we focus each day, how is the patient doing? You know, where are they at in their hospital stay? Do we need to move towards palliative care options? Are we on the right track of getting them back to normal? What do we need to do? So really making that a daily focus with each patient is so important to your mortality rates. That involves your case managers. So really just being close with your case managers helps to get that accomplished. So, you know, once we've gotten our mortality under control, then you look at what are your areas of improvement in bundle compliance. So we all know if you're talking about sepsis, you're talking about a bundle of care. And most often you do have bundles, every facility has bundle challenges. I feel like most facilities, we tend to struggle most with fluid compliance. And like I said, this goes back to finding out what your nurses and your providers feel like the resistance is to completing that bundle. So really being at the forefront of asking them, what do you think is going wrong? Or I see that this didn't go well, what do we need to do differently? Fluid compliance seemed to be one of those things that we weren't completing all the time. So providers would often tell me, well, the patient wasn't hypotensive, they were hemodynamically stable, they didn't have a lactate greater than 4. I didn't really feel like I needed to give them fluids. Unfortunately, we all know to complete a bundle, we need 4 elements: cultures, antibiotics, lactic, and fluid. So I just talked with them. I'm like, well, you don't necessarily need to bolus each patient with 30 milliliters per kilogram of fluid. We just need some sort of fluids given to each patient and monitor them hemodynamically. At some point, we all know that sepsis patients could become hemodynamically unstable, so always assessing them and watching their fluid status is really important. So it was, again, just education with the staff, providers, and nurses about what we can do to help with that bundle element. Also, our next bundle compliance element was antibiotics. So we were giving antibiotics fairly quickly, but our goal for ourselves is to give antibiotics within 1 hour of arrival to our facility. We all know that mortality increases every hour we delay treatment. So, you know, we put that at the forefront with the nurses. We need to give antibiotics quickly and efficiently. So at our facility, anytime a patient meets criteria for severe sepsis, we call a code sepsis overhead. This is meant to be done in the ER, ICU, or medical units. If your patient meets criteria for severe sepsis, we need to call a code sepsis overhead. And as an interdisciplinary team, we come to the bedside of the patient, review what's going on with the patient, talk with the provider, and see where we need to adapt care and administer antibiotics or continue treatment, whatever they decide. So with antibiotic compliance, I've done a lot of work with the ED medical director and the ED nursing director. So on a daily basis, I can currently look at how long did it take from the provider seeing the patient to ordering antibiotics, and then how long did it take the nurse to administer antibiotics once they were ordered. Once we were able to break this down and really show the providers and the nurses where the outliers were, everybody wants to do well on a general basis. And so once you're aware of how you're doing and when it's brought to your attention, you'll really your nurses will work towards doing better. Your providers will work towards doing better. It's all for the outcomes of the patients. And we all know antibiotics are so important to our sepsis patients. This is one way we've really made a difference in our compliance. So year over year, for example, at our facility, antibiotic compliance within 1 year has gone from 50% to 71%. So we have celebrated that. And like I said, we've talked to staff about what barriers they've had, and we've adjusted our processes based on their feedback. It's just been a great success here at Regional. The next thing we've had success with is ED screening, nurses screening their patients for severe sepsis and septic shock. So we talk to our nurses, you know, once your patient comes in, the first thing you do is get a set of vitals, right? So you've done half your sepsis screen right there by getting a set of vitals. So we encourage them, do a sepsis screen right after you get your set of vitals. The nurses really do put a priority on identifying sepsis early. I look at each of those patients that we screen and was the screening accurate or not, and I provide real-time feedback to the staff. This has really helped us identify sepsis early. I share weekly updates with antibiotic and screening compliance with our ED leadership. Those things have really helped guide our compliance rates. We've also assigned sepsis buddies. So our ER charge nurses are often in staffing, and so there's not really somebody that can always, we don't just have extra bodies sitting around, as you all know in your ER. So we assign somebody at the beginning of the shift to be a sepsis buddy. And so when a code sepsis is called, that person finishes the task that they're doing, and then they go help the nurse that had a code sepsis patient, and they obtain antibiotics, they get fluids for the nurse, they get IV tubing, blood cultures, those small things that the time adds up if you're doing it by yourself, but if you're doing it as a team, it really just expedites care. Everybody gets everything done a little bit quicker, and ultimately the patient has better outcomes. So implementing sepsis buddies has been a huge game changer in our ER. It's not been something that I've heard a lot of negative feedback regarding, and the nurses just took it and rolled with it, and they're doing great. So it's all taught them all how to be a little bit of sepsis champions. That's just a few things in our ER. We also call a code sepsis, like I've said, and I make a point as the coordinator. I go down, and each code sepsis, I watch the patient, I help the nurses. What do you need? Giving real-time feedback, real-time education really helps them understand this complex process. It helps the providers understand the complex process. Anything I can do to help and keep sepsis at the forefront of what everybody's doing, it really helps everybody's mentality. And sepsis is a big deal. Sepsis is an emergency, and we need to treat it as an emergency just as we do STEMI, stroke, and trauma. Sepsis is right there with it, and so keeping that close eye on each code sepsis, it really brings the attention to, yeah, this is a big deal, this is an emergency, and we need to take care of our patients. If you're not doing that as a coordinator, I would encourage you to try and do that. It has made tremendous strides in our program. And then lastly, our inpatients. We have at Regional, we have an application called SPOT. It stands for Sepsis and Prevention and Optimization of Therapy. So unfortunately, this is something that is HCA piloted. It's not some application that you can unfortunately download, but it is an automated sepsis tool that monitors each inpatient's vital signs for SIRS criteria and then monitors for signs of infection. What it does is it gives the nurse an alert that they need to do a sepsis screen to monitor for organ dysfunction. While it is an application, I don't know that it's made a huge difference because our nurses are rock stars and have sepsis on the brain all the time. I feel like anytime a nurse sees a new set of vitals, they do a sepsis screen in their head because we put it in their heads that sepsis is an emergency. It's the main thing to do, put it in their heads that sepsis is an emergency and we need to treat it appropriately. I feel like a lot of the nurses, when they see a change in the patient's condition, they automatically do a sepsis screen with each change. And that has brought huge successes to implementing care appropriately and timely. Again, while we have this cool application called SPOT, making sure that on your inpatient side, you don't forget your inpatient nurses. Educate them just as much as you educate your ER nurses and providers, and let them know it's important and that sepsis can happen anytime during the patient's hospitalization, and we need to assess them and treat them appropriately, quickly, and improve outcomes. Those are just a few of the things we've done here at Regional to have some success. We will always be learning and have challenging moments, but we'll always be striving to working towards improvement.
Kaycee, that was a tremendous amount of information, and thank you so much for sharing. As I reflect here, the culture change that has occurred at your hospital with keeping sepsis and harm prevention as the role of the nurse and harm preventionist to monitor for the risk of worsened or new infections, particularly as that worsens into sepsis, what a great job you've done as the communicator of that message at onset, upon arrival for the new staff, physicians, as well as nurses, and throughout the day through the responses to the code sepsis, as well as the communications about your feedback and review of the patient's cases for root cause analyses and mortality review when there's sepsis involved. and constantly reviewing the process and opportunities to improve upon your goals, I think, has been key. And your Sepsis Buddies program in the ER is, I did talk to an ER nurse who was talking about having 3 code sepsises at one time, and I will make this suggestion to Sepsis Buddies because I suspect that not everyone is aware of that. So thank you so much for your constant vigilance, for being a representative for sepsis, like Wonder Woman out there, fighting off whatever comes your way and being strong and carrying that message forward on your goals within Joint Commission certification. And I just really want to thank you for sharing, and I know that everyone will get some pearls of wisdom out of this. When you talked about your fluid bolus opportunities, your antibiotic administration within 1 hour, and also your screening accuracy. I've heard from other hospitals, sepsis coordinators, that those are exactly the same things that they're working on. And we've made tremendous progress in Indiana, but I know that you there have made a great amount of progress in reducing sepsis mortality. So thank you for sharing your information this month, Kaycee.
Well, thank you. And it takes a team, and so every hospital can learn a little bit from each other, and that's what's important. So it's awesome to have this coalition.
Thank you.